Thank you, my dear professors. It's my pleasure to be here today in our annual radiology conference. My talk today is going to be regarding the laser ablation in thyroid nodules. My agenda will include what's a thyroid nodule, what's laser ablation, which thyroid conditions that can be treated by laser ablation, what do we expect prior, during, and after the procedure, and the laser ablation versus the radiofrequency ablation. Thyroid nodule constitute a frequently seen clinical problem. The incidence of thyroid nodule has increased with the increased use of thyroid ultrasound. Most thyroid nodules are benign and require no treatment. However, some of them may need treatment due to pressure symptoms, cosmetic manifestation, and some hormonal disturbance. As curative surgery has several drawbacks, non-surgical, minimal invasive, using both thermal, ultrasound guided using both thermal and non-thermal technique was used with favorable response for treating benign thyroid nodules. The laser ablation is the first technique to be introduced for treating benign thyroid nodules. Which thyroid condition can be treated with laser ablation? We usually treat the benign symptomatic solid nodule that induce dysphagia, dyspnea, cosmetic disfigurement. What about the cancerous nodule? Laser ablation can be used in treating recurrent inoperable thyroid cancer. It is not the primary way of treatment for primary thyroid cancer. However, it can be used in small cancer in which the patient is not candidate for surgery and when radioactive iodine isn't effective. Also, it can treat metastatic cervical lymph nodes when radioactive iodine is not effective and when the patient is not candidate for surgery. What about hot nodules? Some thyroid nodules produce too much hormone called autonomous thyroid nodules. These nodules can be treated with laser ablation and the patient will achieve euthyroid state in 50 to 80% of the cases after ablation. What about the cystic nodules? Cystic nodules can be treated with alcohol ablation, and it is effective in treating them better than laser ablation. What do we expect prior to the procedure? A clinical visit with the interventional radiologist is first done, in which the interventional radiologist will review the laboratory investigation of the patient, including the CBC, the INR, and the coagulation profile. Also, abnormal thyroid hormone must be corrected before doing the laser ablation therapy. Also, we have to review the results of the fine needle aspiration cytology to confirm the benign nature of the thyroid nodule. A planning ultrasound is done, and it is recommended to have a multidisciplinary team to evaluate the case by an interventional radiologist, a surgery, and an endocrinologist. Laser ablation therapy is minimal invasive outpatient procedure. During the procedure, the patient lies in the supine position with a hyperextended neck. A peripheral venous access is obtained and vital data is monitored. What about the sedation? Conscious sedation and or local anesthesia are usually used. However, we don't recommend local anesthesia to allow direct feedback of the patient while performing the laser ablation in order to decrease the risk of complication. Then a planning ultrasound by high frequency ultrasound probe is done, and laser protective goggles must be worn by the patient and the doctor. A planning software is usually implemented within the ultrasound devices and the echo laser devices. What is the idea of planning the treatment? First, we have to know the number of introducer needle and introducer fiber used. We can use up to 5 needle and 5 fibers. We have to check the longest axis of the thyroid nodule and introduce the needle with the longest axis of the thyroid nodule, because this will improve the treatment efficacy. And we have to be away from the vital structure such as the carotid vessel and the nerves. Also, planning the technique, planning the laser ablation is we have to check the illumination energy delivered, and we have to check the number of pullback technique as regard the distance and the number done during the procedure. This is a case done in our interventional radiology unit. It is done by my colleague Karim Abtawab with the assistance of my colleague Rana Tari and my assistants. First, planning ultrasound was done. We decided to use 2 introducer needle and 2 optical laser fiber in this patient. First, we disinfect the target zone. We place the guide system on the patient neck. We start by introducing the first introducer needle, which correspond to the last line. Then we introduce the second needle, which correspond to the third line. Then we check the tip of the introducer needle in order to be away from the vital structure, and we start our laser session. This is the ultrasound images in which we introduce the needles. Then after the beginning of the session, we can see the air bubbles. After finishing the laser session, a contrast enhanced ultrasound can be used. However, it is not used in our institute. And this image shows contrast perfusion within the center and within the periphery of the nodule before ablation. And after the ablation, we can see that the enhancement is just at the periphery with complete absence of enhancement at the center of the nodule, indicating adequate ablation. What to do in case of patient concern while performing the ablation? If the patient develop pain reflected to the back of the neck or the head, and in some cases the patient may develop cough due to trachea infiltration, first thing we should do is to assess and repositioning of the fiber tip in order to be away from the thyroid capsule. If one has no effect, we can turn off one source of the laser and go on with the other one, if we are using a 2 laser fiber. And in very rare cases, persistence of cough may need to terminate the procedure. After the procedure, a follow-up interval during the first 24 hours and within 1 to 6 months is done in order to assess the size of the nodule and the decrease of patient symptom. Usually there is gradual improvement as regards the patient symptom and as regards the size of the nodule. Some patients with larger nodule or suboptimal primary ablation may need additional ablation sessions. This is the size of the nodule before, then 1 month, and after 6 months, and 12 months after ablation. The question asked by the patient, will I have to take thyroid medication after laser ablation? Actually, laser ablation target abnormal thyroid tissue, and it will not affect the thyroid function. So usually the patient will not require medication after the laser ablation. However, in patient with pre-existing Hashimoto condition, they may have to complete their medication, which is not related to the laser ablation. Also, the patient with autonomous thyroid nodule in which there is too much thyroid hormonal secretion, the laser ablation, in these patients, they may achieve euthyroid state in about 50 to 80% of patients following the ablation. So is the laser ablation therapy safe and will it leave a scar? Actually, laser ablation therapy is safe and it leaves no scar. It is a minimal invasive technique with adequate response in good interventional radiology hand. What about the complication? Complications are classified into major and minor complications. The major complications are rare. Sometimes voice changes can occur. The voice changes usually disappear without a couple of days and up to 3 months. We can use fiber optic laryngoscopy to diagnose the ipsilateral vocal cord palsy, and usually it is just treated by corticosteroid. As regards the minor complication, subcapsular or perithyroidal hematoma may occur following the ablation, and it is just treated by gentle compression and cold fomentation. Skin burn rarely occur, and it is just treated by antibiotic for 10 days. Intraoperative vasovagal reaction may occur, just treated by putting the patient in Trendelenburg position. Cough usually disappears after finishing the laser session. mild to moderate pain and fever, and it is controlled by analgesic. The laser ablation versus the radiofrequency ablation. Most studies shows that both laser ablation and radiofrequency ablation showed nearly similar outcome in management of thyroid nodules. But laser ablation was slightly more effective than radiofrequency ablation in large one. The success rate and safety profile were comparable in both methods. However, laser ablation is more costly than radiofrequency ablation in large nodule, as we used many number of laser energy fiber. However, operator skills could be crucial in determining the extent of nodule volume reduction regardless of the used technique. So in conclusion, most benign thyroid nodules are asymptomatic and remain nearly stable over time. However, progressive growth of these nodules may lead to patient concern and repeated medical consultation and thyroid surgery. Laser ablation of these nodules is followed by relevant reduction of its volume with improvement of mechanical symptoms and undesirable cosmetic appearance. High rate of volume reduction continue up to 12 months with maintained thyroid function. Laser ablation is advisable in larger nodules compared to other thermal technique with relatively lower risk of major complications. So, laser ablation therapy is clinically effective, well-tolerated, and safe minimal invasive technology for non-surgical management of symptomatic benign thyroid lesions. Thank you.
Thank you, Dr. Ahmed. And now we shift to